Good morning, good afternoon, good evening, wherever you are in the world, and thank you for joining us today. I'm Emma Rule, your moderator for today's event, and a senior researcher here at the United Nations University's International Institute for Global Health. Based in Kuala Lumpur, Malaysia, IIGH is one of 13 institutes that make up the UNU and is the UN's designated think tank on global health. Our work centres around three pillars: the generation of policy-relevant research and analyses, particularly with respect to gender and health, the translation of evidence into policy, and the strengthening of capacity for local decision-making. In early 2019, IIGH embarked on a journey to understand the decolonisation agenda within global health, what that might mean for us as an institution, and what we could contribute to the broader discussions and calls for change. It started with a very necessary reflexive examination of our positionality, both as a UN institution based in the so-called Global South and as individuals. We also conducted an analysis of the Decolonizing global health literature and had many thought-provoking conversations with people that generously shared their time and inputs as we sought to better understand the topics under discussion and to identify individuals and networks agitating for change. I've been fortunate to be a part of this endeavour since its inception, and this milestone would not have been possible without the rich contribution of colleagues, both past and present, to the development of our thinking. It's been a long process, both consultative and collaborative, to get us to where we are today. We've seen that there is no single movement to decolonise global health, rather a diverse plurality of initiatives reflective of the complex and contextual nuances of reimagining global health. A common point of unity, however, has been a clear push for the need to move from theory to action and to hold ourselves and each other accountable for making the change that we want to see. So with that, I have the pleasure of introducing our four panelists for today, who will talk about the ways in which colonialism and coloniality manifest in their global health work, and really representing views and stakeholders from across the global health ecosystem, and some of the ways that they've sought to counter these forces. David McCoy is the research lead for IIGH's Evidence to Policy work, under whose leadership the programme of work launching today sits. Prior to IIGH, David was Professor of Global Health at Queen Mary's University, London, and has previously worked within civil society, including as a member of the Steering Council of the People's Health Movement for 10 years, and in the public sector, including during the immediate post-apartheid transformations of South Africa's healthcare system. David will be followed by Sabina Rashid, the Dean of BRAC's James P. Grant School of Public Health in Bangladesh, where she is also the Director of the Centre of Excellence for Gender, Sexual and Reproductive Health and Rights. Highly respected both at home and in international fora, Sabina sits on the advisory panels for several organisations spanning health systems and policy and human and reproductive rights, and is a member of the national working group Bangladesh Health Watch, a multi-stakeholder civil society advocacy and monitoring network dedicated to improving the health system in Bangladesh. Next, we'll continue to move west over to Uganda. Danny Gotto is the founder and current executive director of Innovations for Development, a development practitioner with over 20 years of hands-on experience designing and implementing both medical and community health initiatives. Danny is a vocal champion of the right to health in sub-Saharan Africa. Our final presentation today will be given by Anna Marriott, the Health Policy Manager for Oxfam and the co-policy lead for the People's Vaccine Alliance. Anna has led Oxfam's policy and influencing work on healthcare for the last 15 years and has published several papers on health financing and healthcare delivery, including on the risks of increased commercialization. During the pandemic, she has played a leading role in making the case for COVID-19 vaccines as global public goods. After the presentations, we'll open the floor for Q&A. We are really grateful to see the fantastic audience that has joined us today. And we know that with the number of people joining us across YouTube, Zoom, and Twitter, it's just not going to be possible to involve everybody in the way that we might like. But please be assured, today is just the beginning of this next step in our journey. Over the coming months, we will continue this conversation, both online and in person, and we're actively seeking collaborators to join us and to continue to work with us. With that, let me just give you a few housekeeping reminders. We want this to be as lively and engaging as possible, so please do use the chat boxes or comment sections on whichever platform you're joining us from. Add your name, let us know where you're from, and also add any questions that you have there. We'll be using those to put to our panelists in the second half of today's session. Please also feel free to share your thoughts and comments and do express yourself with emojis. But most of all, take this opportunity to participate, to take note of who we are and where you can find us, and to enjoy. You can also follow this conversation on UNU IIGH's Twitter, on LinkedIn, and on YouTube. And it also means that recordings of today's sessions will be available on those platforms once we've finished. With that said, I'd like to pass over to our first presentation for today. David, over to you.
Thank you, Emma, and greetings to everyone. Now, very inconveniently, I've come down with a chest infection, so apologies in advance for my croaky voice and in case I end up coughing too much during this presentation. So what I'm going to do in this presentation is to really try and set the scene for Sabina, Danny, and Anna by making some introductory comments about colonialism and coloniality more broadly, and how we see colonialism and coloniality intersecting with global health. But before I do that, as you can see on this slide here, I actually want to say something about the 1978 Alma Ata Declaration. Now, this key and important declaration is commonly associated with primary healthcare, but I would argue that it should also be seen as an early manifesto of global health. This was well before the term global health was even being used. If you read the text carefully, you can also see it as being a clarion call for a decolonized world. So, for example, under clause 3 of this declaration, it talks about a new international economic order as being fundamental to reducing the gap in health inequalities between developing and developed countries. It talks about health promotion and protection as being essential to socioeconomic development and world peace. Clause 7 emphasizes an approach to healthcare that is socially, culturally, and politically appropriate and rooted in communities. An approach to healthcare that is bottom-up, which sees the health system as an engine for wider social development and empowerment. Clause 9 speaks about international cooperation and partnership, and Clause 10 calls for the better use of the world's resources and a genuine policy of independence, peace, détente, and disarmament. Before making reference once again to international cooperation and a new international economic order. However, as we know, the Alma Ata Declaration was quickly undermined and replaced by the narrow and conservative ideology of selective primary healthcare, and then subsequently buried under the debris of the debt crisis, structural adjustment programs, and the emergence of a dominant neoliberal policy paradigm that shaped the subsequent 4 decades of globalization, and that, in my opinion, has not enabled fair and sustainable development. Next slide, please. So that, I think, is important. The Alma Declaration is an important historical touch point for our current conversations about decolonizing global health. But what do we mean by colonialism? And here, I think it's useful to have a working definition of this term and to see it as consisting fundamentally of 2 parts. Firstly, there is a domination and subjugation of one group of people, a domination and subjugation of one group of people by another. And secondly, it is this relationship of domination and subjugation that enables exploitation and the extraction and appropriation of resources and wealth. So using this definition, we might conceptualize colonialism as a phenomenon that may occur within countries, may occur between countries, and it also occurs across countries. it may operate at a local level, or as in today's globalized world, it may operate at a global and transnational level. It's worth also noting that the expression of dominance within a colonial relationship may be overt, explicit, and brutal, but it may also be subtle and sometimes even hidden in the guise of charity or aid. Next slide, please. I think the term neocolonialism is also important for two reasons. Firstly, it draws attention to the fact that colonialism can occur indirectly through economic structures and systems without direct colonization or occupation. Next slide. And secondly, because it dispels the notion that we're living in a post-colonial era. We're not. We're living in a neo-colonial era, as exemplified by these headline figures from an analysis conducted by a consortium of NGOs in 2017. Next slide. But perhaps nothing speaks more to colonialism as a contemporary and global phenomenon than these figures from Oxfam. I mean, this staggering, eye-watering, and in my opinion, uncivilized level of inequality, which also includes an immense concentration of power and influence by a tiny sliver of humanity, is neocolonialism writ large, with vast amounts of wealth being hoovered up by a tiny number of people. Next slide, please. So if that is colonialism, what do we mean by coloniality? This term is important because it describes the ideas, beliefs, and narratives that help to legitimize and sustain colonialism. There are many different ideas, there are many different beliefs and narratives used in different ways to enable exploitation and the extraction and appropriation of wealth and resources. Next slide. Perhaps the most common are the racist ideas, beliefs, and narratives that allow some people to dehumanize or subhumanize others, sometimes as a pretext for extreme brutality and violence, as depicted here with the slave trade. It can even be used to legitimize genocide or to infantilize and degrade the dignity of others, as depicted in this equally horrible picture here on the right. Next slide. We also believe that there's a clear gendered dimension to colonialism and coloniality. There are societies where women are dominated and subjugated by men and economically exploited, especially in terms of the disproportionate amount of unpaid and unvalued care work done by women right across the world. There are also many examples of racism having a clear gendered dimension. Next slide. Finally, another important set of ideas, beliefs, and narratives that are important parts of contemporary colonialism are those that argue that there is no better alternative to the dominant neoliberal policy paradigm, which has produced the massive inequalities that we see today and that enable this massive concentration of power in the hands of the few. Now, there's an important and much longer discussion to be had about the history and ideology of neoliberalism and how it relates to contemporary colonialism. But two commonly presented ideas of mainstream economics that may be most relevant to our discussion today include the idea that billionaires are wealth creators as opposed to being wealth takers, and that the strengthening of private intellectual property rights encourages scientific innovation. Both, I would argue, are false economic ideas which have instead enabled colonial relationships to thrive. Next slide. There's also a long history of interconnectedness between colonialism and the ecological crisis we all face. It's a colonial mindset that sees the planet as a resource to be plundered. It's a colonial mindset that pays no regard to destroying the habitats of other species. And it's a colonial mindset that has failed to understand and has at times even destroyed the knowledge systems and philosophies, in particular of indigenous cultures, that prioritize our living as humans in balance with nature. Sorry about that. Now, next slide, please, Anne. Now, one result of this mindset is also a form of intergenerational colonialism, whereby present and past generations have essentially stolen from future generations, as described in this quote here. So I hope I managed to paint a comprehensive and multifaceted picture of colonialism and coloniality. This is a broad brush picture of what colonialism and coloniality is today, and how it manifests. But how does this all relate to the global health system or to the global health community? And what is it about the global health system and the global health community that needs to be decolonized? And how do we move beyond discussion and analysis to practical change? Now, we don't have all the answers, but in launching this program, we hope to engage with others to encourage debate and provide also a safe space for uncomfortable and risky conversations. Confronting power and shifting power is not easy and often comes at a price. And above all, as Emma said earlier, we want to find a way of catalyzing action in a progressive direction. Next slide. So to move us forward in a comprehensive manner, we've set out these three intersecting dimensions of a decolonizing global health agenda. And hopefully these will be elaborated on by our panelists. Next slide. The first is colonialism within global health. Here we really focused on the power asymmetries within the global health system, the continuation of exploitative relationships, and perhaps what could be described as false partnerships within the global health community, as well as ideas that buttress or continue to buttress unequal relationships. Next slide. Second dimension is about the colonization of global health itself, looking at how powerful actors are able to dominate and control the structures and systems of global health governance, to dominate and control the policies, the financing, and the narratives that are prevalent within global health. And then finally, and thirdly, colonialism through global health. And here we're talking about mechanisms by which the global health system acts as a means of exploitation, extraction, and appropriation. And we have seen, for example, recently vast degrees of undeserved and morally unacceptable profiteering over COVID in the pharmaceutical sector, which Anna will speak to. And then secondly, the way in which the global health system or the global health community may sometimes act as an alibi for colonialism. The way in which we involve corporate actors that cause great deals of harm as partners in our global health programs, and sometimes also the use of the reduction in mortality rates, which is a great achievement of global health, but which can sometimes be used to divert attention away from the need also for more transformative social and political change. So with that, I hope I've set the scene for our three panelists. Thank you very much for listening, and over to you, Emma.
Thank you very much, David, for what was a really interesting and important reminder of the very contemporary nature of the challenges that we face, partly as a result to the very historical and structural legacies of global health. So with that, over our next three panels, we're now going to start to explore elements of that ecosystem in more detail. So I'd like to pass over to Sabina Rashid to tell us more about the work that they've been doing at BRAC. Thank you.
Thank you so much. That was very, very useful, David, with your comprehensive overview. So I'm going to take some of those discussions and concepts and share with you practically what that means working at the James P. Grant School of Public Health. I've been here for 18 years. And when they first set up the school, It was literally a cut and paste curricula from a very well-established Ivy League in Bangladesh at the BRAC school in 2004. While some of the elements of that curriculum were very useful, there was plenty of disconnects between what our contextual realities are and what public health curricula should look like, or at least be taught, and on what are sort of the additional competencies that are required in our context was definitely not there, because that was much more for a Western audience with different health systems, different structures, different social economic realities. So just to say that I think one kind of inheritance of this sort of legacy of colonization is we still have a certain understanding of what to value, and who has knowledge and who's given value for that knowledge. And there's a hierarchy, and we kind of fit in somewhere in that hierarchy. But I would say in the last 10 years, there's been a lot of change and shifts, because we quickly realized, at least in our Bangladesh context, that curricula, we needed to move away from just a purely cut and paste, adapted from North America curricula, and bring in much more sort of studying around sort of our culture, history, traditional understandings of body, illness, and health. We brought in a lot more community engagement, which was students spend time in slums, in rural areas, learning from communities, contextualizing public health through looking at a more holistic approach, looking at housing, water, sanitation, and very, very poor, disadvantaged communities. So there was kind of a shift. And then if you look at faculty, I mean, I still struggle with this in proposals and the work we do, is that they're very fixed ideas of who represents a professor or a faculty. And we have plenty of professors with PhDs, but we've also brought in practitioners. We're not the only ones to do this. I remember being quite impressed going to one of the schools of public health in South Africa and finding that they have a range of practitioners who co-teach and facilitate different classes and sessions with professors, because they're implementing. After all, what is the aim, at least from my end as a dean and a professor of a school of public health? We have international students from all around the world, that a master's program is extremely important to improve the lives of the poor, improve health. And to improve health, you need to have practitioners, you need to have implementers, you need to have people from across sectors. And in our NPH program, we've done that. And that moves away from a certain notion of what is a good public health education. What do we value? And sometimes it's the contextualized realities that are missing, because we look up to or look to really the global north to guide us and we devalue a lot of the knowledge, the innovations and solutions in the global south. I come from a country in Bangladesh where BRAC is a large NGO that's led the way in development and health, where Mohammed Yunus from Grameen Bank set up microcredit that is replicated all over the world. And it's often this sort of internalized kind of devaluing and then external devaluation that we forget about. And we need to critically reflect on this. I mean, I've had the privilege of being in this institution where I've been part of, and along with others, led a change to bring in the best from both elements of curricula. Finally, I think I want to say is that we talked a little bit about this whole public health, which is very biomedical. And that's also very a Western valuing of biomedical and biomedicine. And really in many of our countries and many parts of our world, first of all, you have pluralistic health systems and also indigenous notions of the body, self, and illness that we really need to teach our public health leaders about, our graduates, because, when you deal with communities, you want to improve health, you have to engage beyond a biomedical notion of public health. And Ghaffar and I and a couple of deans from other schools of public health, said that with COVID, we really need to revise the way we look at public health education. I mean, even if you look at health systems, we need to look at, in our context, procurement, supply chain management, more specific contextualized issues in these countries, and also contextualized solutions. Solutions for some other country is not applicable for our country. And that's why what I see is when you have policy recommendations and development tourism, where you have development agencies coming in and making sort of all kinds of policy recommendations, there's a mismatch, there's a misfit. There's a lot of people who are working for a long time in development in different countries, and they come with an expertise. So I don't also want to say it's about the North and the South, because it's a lot more messier than that. It's about engaging in and trying to understand and valuing knowledge and valuing and understanding that all kinds of knowledge are critical and knowledge is multi-directional, and teaching and learning has to be contextualized to have good schools of public health and have curriculum that is adapted and refined for the needs, but also I think a historical kind of perspective on where we're coming from. I mean, I'm going to stop there because I know we have 8 minutes, but I can talk a little bit more about this during the question and answer, unless I have more time. Yeah, thank you.
Thank you very much, Sabina. And so many topics there that I can see that we will want to dive into. So of that talk that have really spoken to you. For those of you online, please do put your questions into the comments section or and into the chat so that we can post those to Sabina as we move into the Q&A. But for now, let's move over to Danny. Thank you very much.
Yes. Hello, everyone. First of all, I'm very glad to be here, and I congratulate the Institute for this milestone of setting up decolonizing global health discourse. This has come handy at the right time when this part of the world is grappling with some of the key challenges that David has well elaborated. I want to begin with my journey in the global health. Of course, I'm a public health physician. I started as a medical practitioner. I've worked in all sorts of settings, both public facilities run by the state. I've worked for NGOs. I've worked for programs funded by PEPFAR, USAID, DFID, and to name it. But one thing that kept coming through is the story of Africa. Of course, this story has been told and retold. But when we look at the numbers, Africa is 17% of the global population, and 28% of the global disease burden is in Africa. We have 75% of the poor people across the world are in Africa. And estimates are showing by 2030, 90 or 95% of all poor people will be in this part of the world I call home. The question is that why, for so many years of, a lot of people celebrating how they are working in Africa, we've remained the poorest. Not because we lack resources, we are the most resourced continent. We have 30% of the fresh water. We have 60% of the arable land in the world. But we contribute nearly 50% of the numbers on hunger. So the question that used to come into my mind as a public health student and as a physician is, how come that the rest of the world has contained malaria? The rest of the world has figured out with diarrheal diseases. The rest of the world has addressed some of the challenges that we're having, but we are not. Then much later, I came in contact with NGOs. I saw firsthand how NGOs designed programs. Most of the time, interventions were designed outside Africa, launched into Africa, and numbers are picked from communities and celebrations are done, but nothing fundamental is changing. It is estimated that for the last 30, 40 years, Africa has received about $2 to $3 trillion in development assistance. But when you look, nothing is. What is happening? Then somewhere, somehow, I got to learn about the discourse of coloniality and decolonization. And I dug deeper into understanding how was power playing, what role was Africa playing in contributing to the problems, what externalities were we suffering from that were making us vulnerable to this extent. Then I discovered that the game is not for us. The system was never designed for us to break out. We were subjugated, as like David shared, and we continue to be subjugated. We don't grow what we eat. We don't produce what we use. Everything that we produce goes out. We are paid peanuts. Our economies cannot sustain incomes that can meet the health needs of our people. So aid becomes the only alternative if we don't fight back. That comes in to solve the problem. So moving on, I much later now, saw the structured adjustment programs, how they defunded health, deindustrialized much of our industries, because we were being lectured to by those with power and money that governments have no business running business. So the private sector should lead and the private sector should invest. Africa missed out. We didn't see the private sector. The small little private sector was incapacitated. The one we had internally was incapacitated in my countries. A lot of factories that we had that were, financed by the state were defunded. We've seen a net migration of health workers to the developed north. They have not recognized this migration, and by the time the HIV epidemic came in 2000, at the peak of the epidemic, our health system was crumbling. So we had to reinvent ourselves by designing community health worker programs, volunteers coming to reach out to communities and supporting to give some bit of response. NGOs came, they pondered on the idea, disorganized it through sometimes useless money, and they left. Others, new ones came, they formed a silo approach, disease-based programs. They cherry-pick diseases of interest to them. Now, a wider mass of people were left out. I give you an example. I've worked in the HIV sector for the last maybe 15 years, I should say. 90% of the HIV funding in my country is by the United States government, primarily PEPFAR. That money, 90% of it is going through international NGOs. They are the ones who design the interventions, and then, from the American capitals or cities, they bring them to Africa to implement. They employ Africans, give a particular rate of salaries. Because of the interests and the opportunities that come with NGOs, we've seen a migration of health workers from the health sector to work for NGOs. Remember, we have a small pool of human resource. Most of them have migrated out. Others are seeking and struggling to work for NGOs. As you know, much of the NGO business, the model is 5 years, invest, move out. Then you see health workers moving from one project of nutrition to HIV, to maternal health, and there's no consistency. There is no sustainability. So that confusion has created the continuing disease burden. Then we saw international mechanisms like Gavi, like Global Fund coming in. When you read their literature, they are saying we're building Africa's health systems. But surprisingly, which came out in the period of COVID, Africa only produces 1% of the vaccines that it uses. For heaven's sake, you've been in Africa for 10, 15, 20 years, and the people you're claiming to support do not produce the vaccines. Whose vaccines are you promoting in Africa? How come that Africa cannot produce its own vaccines? Is it the lack of institutions? Is it the lack of our technical know-how? What role have you played in building the technical know-how so that we know that you've tried? Zero. Much of the relationship is, of course, extractive. We've seen their investments promoting their technologies and products, introducing them to our people and locking them. The classic example is the COVID time. When we were crying out 2 years back. The rest of the world were getting jabbed. We didn't see vaccines. Countries like Canada, the United States, were, having stockpiles of vaccines. None was given to us. When we started making noise, the only thing they would think about is donations. Now, this is the thing that donation did. We had created networks and relations with, for instance, China. China was producing vaccines. Now, when they heard that we're picking vaccines from China, they introduced theirs. They gave them free. Now, when you introduce free vaccines good enough, you give for the first time free, you lock the population. Now, once you lock the population, they pick interest in that, then the alternative is that our governments need now to go back to the companies to buy. Why? Because they cannot accept us to have the intellectual property rights to reproduce the vaccines. They still want us to do the same and same. So with that, I think we need to get back to the drawing board. We need to push back. We need to localize our efforts and our health. We need to deconstruct the systems and structures that have made us vulnerable to most of these global health issues. So I thank you. I think I stop there for now.
Thank you very much, Danny, for that a really striking set of figures. And a reminder that even as we think about global health, that really there are so many different aspects of society in our day-to-day lives that touch on health and health systems. And your comment about systems that were never designed for us has really struck me, and I think is one that we will come back to along with the vaccines conversation in the Q&A. And so for now, I'd like to pass to our final presenter for this part of the of today's event. So Anna, over to you.
Thank you very much, Emma, and thank you for the privilege of being part of this really fascinating conversation today. And I'll start really, I think, by building on some of the points that Danny has made. During the pandemic, I've had the privilege of being part of an amazing movement calling for a people's vaccine, one that is a global public good, available to everyone free of charge. We reached an extraordinary moment in 2021. We had rallied world leaders. We were speaking to governments, scientists, to high-level advocates across the globe, supporting a proposal led by South Africa and India to upend pharmaceutical monopolies and share the rights and the know-how of the COVID-19 vaccines so that production could be ramped up across the world and we could redress this deadly divide in access. The White House was interested. It then publicly supported the idea. We honestly couldn't believe it. And then suddenly the racism turned up. One after one, pharma executives and their sponsored experts began telling publics that actually letting developing countries manufacture vaccines would be a problem. They wouldn't get it right. They don't know how to do it. It would be unsafe. The narrative was championed by some of the richest people on the planet. For me, this story goes to the heart of what I wanted to talk about today. The inequality in health has deep roots in inequality in power and wealth, and the abuse of that power for the benefit of the few at the expense of the many. The truth, as we all know, before COVID, the vast majority of the world's vaccines were already manufactured in the global south. The real story. By that time in 2021, when the pharmaceutical sector ramped up its racist narrative, Pfizer and Moderna were making $1,000 a second in profits. Monopolies had created 9 new vaccine billionaires. Despite enormous public funding, rich countries and the global health architecture they finance enabled and protected the privatization and monopolization of these vital pandemic tools. Decisions about who lives and who dies from COVID-19 were outsourced to the CEOs of Big Pharma. A common sense, fair, and honestly not very radical solution at the heart of a global pandemic was put out of reach because of an unfathomable power differential between Big Pharma and billions of people. The pandemic, arguably more than anything else before it, has has revealed just how urgent it is to expose and challenge the extreme inequality in today's global health decision-making, and to investigate and reveal its real winners as well as its losers. At the heart of Oxfam's health work over the decades has been an intent to expose and challenge the harmful, inappropriate policies born out of structural inequalities in global health and the wider development architecture. For the last 15 years, we have tracked the shape and impact of a new era of donor-driven privatization of healthcare, like the importation of health insurance policies in the name of universal health coverage, which serve to enrich commercial healthcare providers with scarce taxpayer funds while failing to protect patients from exploitation and financial ruin. We've investigated World Bank-supported health PPPs in countries like Lesotho that diverted more than half of the entire health budget to deliver 25% returns for private investors. This notorious and unsustainable PPP collapsed at the height of the pandemic. And during the pandemic, we saw countless appalling reports of corporate hospitals either shutting their doors to desperate patients or charging hyperinflated prices. Oxfam's work tracing the complex web of financial actors invested in these and other exploitative corporate hospitals in the global south reveals that many of them are directly bankrolled by the governments of the UK, France, and Germany, as well as the World Bank via their development finance budgets. That rich countries are in the driving seat of the multilateral institutions with outsized influence on global health is a given. Any illusion of change for the better on this front was shattered for me this year at the WTO Ministerial, where I witnessed a handful of rich countries literally lock out the rest of the world's representatives to cook up a woefully inadequate outcome on vaccine access. But today's global health architecture is way more complex. The rise of global public-private partnerships, at least in the early days, was heralded by some for giving greater voice to both lower income countries and civil society. Less critiqued was the decision to invite in corporate actors as equal partners, as decision makers for how billions in public funds should be directed. Conflicts of interest have been increasingly normalized, and with it, the ever more chaotic proliferation of opaque and unaccountable partnerships, ever more blurred lines between decision makers and those engaged in unethical profiteering and wealth extraction. Should we be surprised in this context that in response to the pandemic, the CEOs of two of these global health PPPs became the self-appointed designers and leaders of the world's largest ever publicly funded vaccine procurement mechanism, COVAX, without any meaningful participation from the countries intended to benefit? That billions were paid to pharmaceutical giants for contracts with zero transparency and no accountability, including when those corporations failed to deliver. Driving, shaping, and financing much of the change in the global health architecture is a philanthro-capitalist that so many in our community avoid talking about. This is unfortunate. Bill Gates has dedicated huge volumes of his wealth to the task of improving health in lower income countries. Whether you agree or disagree with his vision and approach, the size of his contribution has given him unbridled, unaccountable influence in determining which health challenges the world prioritizes and how they should be solved. Many a time over the last 2 years, I chatted with allies about how dramatically different things would be if Bill Gates supported a temporary suspension of pharmaceutical monopolies, only for us to quickly move on to the question of how it came to be that the opinion of one extremely wealthy, unelected man from the US matters so much. And that's the point, it really shouldn't. For me, colonialism, the comprehensive contemporary version as framed by David and IIGH, is a valuable lens through which to critique and assess global health. Most usefully for me, it provides guidance and focus on where and how inequality in power and wealth can and should be exposed and challenged. And just some final thoughts on this. Decolonizing global health can't stop at fighting for a seat at the decision-making table, but must be about removing others with vested interests from that table, about understanding and challenging how inequality has shaped and influenced the decisions on offer at that table, about exploring and interrogating in the first place if that table should even exist. A colonialism lens reaffirms to me that we cannot and should not divorce the struggle to decolonize health from the broader fight for new policy systems and laws that actively tackle extreme economic inequality and that boldly shift power. We can't hope to decolonize health in a free market. We need new rules, rules that address corporate concentration, that uphold the right to health above the obsession of protecting property, that end profiting from pain. We need the global health community to get behind the call for wealth taxes, to raise new and progressive revenues for health, yes, but critically also to curb the excessive unaccountable power and influence of those with too much wealth. And finally, this must be about new voices. We don't need billionaires spouting racist lines dictating the global health agenda. There is a phenomenal array of health and more broadly economic thinkers, practitioners across the South and from working class and diverse communities across the North. We've got a job to do in hearing these voices in every space for decision making in global health. Thanks. Back to you, Emma.
Thank you very much, Anna. I think so much in there to pick up on, and again, just a reminder of how broad and complex this topic is. Particularly excited to dive in a little bit more to the conversations around accountability. But first, before we get there, I'd like to start with one of the questions that we've had in the Zoom chat, which I think is a really key one and sets us all up. And so an unnamed participant, but thank you very much for your question, has asked a question around domination and subjugation and how much that has influenced internalized mentalities when it comes to who is exploited and who exploits. And I wonder, before we dive into some of the practical changes that you're making, if anybody would be willing to speak about the importance of this topic and recognizing with internalized coloniality as we embark on this journey. Sabina, please.
Sorry, can you hear me? Because my internet's not the best.
We can.
I mean, really, when I was listening to all the speakers and I saw the questions, it made me think about really it's about power, privilege, politics. It's about money. And it's not always, yes, we have the North and the South, and we've got these, oppositional sort of characters from historically with colonization, but we've got these messy spaces with commercial determinants of health. We've got greed, we've got consumption, we've got commercial determinants of health, we've got all kinds of things coming into play. I mean, if we look at exploitation and domination, of course, if you look at, if I stick to even curricula and research, often who are the decision makers around curricula? How come there's a continual devaluation of our own kind of research and curricula? We've fought back, we've changed the systems, and you can. But you have to change it within, you have to be, unfortunately, you have to be part of the system. So be part and parcel of those positions of privilege in terms of having voice or a seat at the table, in many cases, to then push against those sort of understandings. I don't know if we can change systems and structures, but you can at least talk about some of this and change within your own organizations. At least with our teaching, we've really overhauled our curricula to make it a combination of making it much more contextualized. But if I look at power, privilege, and politics, and if it's about money, you've got issues within our own countries and across countries. That doesn't take away accountability because we've got systems that have created sort of monsters, and then we get co-opted. And then once you get co-opted, I think it takes a lot of courage to speak out. You can be dropped off committees or dropped off certain kinds of engagements because you've taken the risk to be vocal. But I do think when we are in particular positions of power, at least I'm an academic, I do applied research, I write, it is important to voice from our places or whatever positions we've been given. Otherwise, there's no point in having these sort of seminars. But that's just a quick kind of response. But thank you.
And I think that's a fantastically important point that you've made there, Sabina. One that's come up in other conversations we've had, and Danny, you are next on my hit list to come to, is the real risk that people face when they essentially put their head above the parapet. And it's part of the reason that David was so keen to emphasize the importance of safe spaces for these conversations as we go forward. But Danny, I'd like to come over to you, both to respond to that question, but also related, a question from Joe Wilson, a researcher in Nigeria, who asked for those Africans and individuals that you work with who are already in positions of privilege and working with powerful global health actors, what actions you've seen taking place to change the narrative. Thank you, Danny.
Thank you so much. I think maybe let me start with the first question that you asked about internalized. I look at my governments in Africa, and when we're having conversations with them about decoloniality and what they need to do, I think they are caught up in the struggle to approximate their countries to the measure of the West, where everything is measured and computed based on the interpretation of a system that puts people into particular levels. For instance, my country is struggling to claim middle income, but middle income when 30% of the kids are undernourished means nothing to me. I think we need to unpack all those descriptions and interpretations that have been put forward to us to understand, what does development mean? What does development, if development is not inclusive, there are so many people left behind, literacies are not improving, then it means nothing. I think going to the next question about the risk, I'll give my example. I told you the many years I've spent in civil society and opening up and talking about these things. No one gives you space. Those with money and funding can defund you. So if you are running interventions and programs and you're talking about accountability, for instance, questioning the localization initiative by the United States agency, to say that you promised that you'll give at least 20% of your local investment through local organizations. How far have you gone? Nothing. The system is still the same. International NGOs are continuing to get the money that they claim they are going to give to local organizations. You are isolated. Secondly, even your comrades within countries who are benefiting from the system look at you as a saboteur, someone who is kind of creating confusion to take away the resources, at least that are coming to them in form of employment, that are coming to them in form of the procurement of antiretroviral treatments. So I think that compromises the struggle, because it puts you in a position where you are questioning whether you should continue doing what you do for the bigger good or live to the times, because at the end of the day, everyone needs bread and butter on their table.
Thank you very much for that, Danny. And I'd like to pick up on that final comment that you made, where you talked about the role that we play and how that might compromise the struggle. And so, David, maybe I can put this next question to you. And this question comes from Dr. Anik Gladza, who is a public health physician specialist from Ghana. And Dr. Anik asks us whether the decolonization of global health can really be led and implemented by the same people that caused colonization. And perhaps maybe you could talk a little bit to questions around, if we have very diverse knowledge systems, and Sabina talked about the need to value, to interrogate what we value, and considering indigenous notions of body, self, and illness. What does it mean? But we have a very vocal decolonizing global health movement with a large representative from the global north and traditional power holders.
I think the first point I'd make, Anna, is that this struggle against against colonialism and coloniality is a global struggle. It's a struggle that needs to be joined by people both in the geographic global north and the geographic global south. There are people in Europe and North America who are also being subjugated by a global political and economic system that is unjust and unfair. And this is related to the way in which globalization has created an integrated global economy. So in some respects, I've often talked about, the key distinction isn't about people from this country versus that country, or people of this color versus that color. It's really about people who believe in justice and fairness versus those who don't, versus those who are happy to take more than they should, to appropriate, to extract, and to exploit. So this is, for me, is a common global struggle. And this concentration of power and wealth at the other end is also now increasingly dispersed geographically. We have billionaires popping up in Africa, Asia, and Latin America. They're not all just concentrated in Europe and North America. And maybe just the second thing is that this needs to be seen as a global struggle, because this concentration of power and wealth is also at the root of why we have failed to address the ecological crisis that we are facing. It is vested interests with power and influence that have prevented the kinds of actions and policies required to mitigate climate change and global warming. So it's a global struggle for all of us.
Thank you, David. And picking up on the themes of global struggles, I'd like to cast our memory back to the not so distant past, or present we're still living in, that is the COVID pandemic. And Anna, I would love to put a question to you from Alex in New Zealand that asks about the COVID vaccine. And he asks, what can be done now to increase access to COVID vaccines in the global south? But perhaps more importantly, in thinking about achieving never again, what can be done going forward to ensure that we don't find ourselves in the same position should we be in the unfortunate position to face another pandemic of this ilk, or similar situations in which global public goods will be vital?
Well, thanks for that question, and I'm sure Danny will have things to say in response to it too. I think on the questions of never again, first, there are alternatives. They have received less funding, they have received less priority, but there are alternative models of developing vaccines, distributing the knowledge, the science, treating the science as a global public good, and the property of everybody, rather than this dominant monopoly model that we have seen and witnessed and experienced the catastrophic impact of during the pandemic. There are scientists who have developed patent-free vaccines. The Texas Children's Hospital, for example, is already has developed and is working with developing country manufacturers to further develop and produce these vaccines in the places that have actually been denied access to these. There is a WHO-led collaboration in South Africa called an mRNA Technology Transfer Hub. I'd be interested to hear views from those listening and from the panel as to whether this represents a decolonized model at all, but it is intended to be a global South-led model, developing mRNA technology for COVID, but also for other diseases of priority concern in the geographical global South, in Africa, in Asia, and Latin America, with a vision to transfer that technology to multiple manufacturers across the global South, free of that monopoly, with the freedom to operate, so that those vaccines can be produced, and in the process developing further manufacturing capacity in Africa, in Asia, and Latin America. So these models do exist. I think it was incredibly interesting to be in the UK, where the AstraZeneca vaccine was being developed, to witness the fight and the struggle between scientists actually at the heart of developing that vaccine, who were publicly on record as saying, you know, it's not appropriate to slap patents on these vaccines, and yet through through negotiations with government, through encouragement, we understand from the Gates Foundation, they did enter into a relationship with a big pharmaceutical corporation that did limit who could manufacture this vaccine and who could get access. So I think there are alternatives to draw from, and I think you know, we need to see support, we need to see political capital invested in these alternative models to make them succeed, to demonstrate that there is an alternative way of doing this. There are opportunities through the process of developing the pandemic treaty. There's negotiations around that could open the way open the way for these alternative models as well. And in terms of addressing the vaccine divide now, I mean, I'd love to hear from Danny on that. I think, you know, Danny spelt out very clearly that when the vaccines were needed, they were not there. And now we're seeing governments around the world facing multiple crises that are diverting attention from the need to vaccine, that are diverting resources available to vaccinate. So yeah, I'd love to hear from Danny on that.
Yeah.
Please, Danny.
Can I go? Okay. Thank you so much, Anna, for that. I think what is happening here, of course, indeed, we need the vaccines, but what we've found out is that it is easier if vaccines are produced or refilled in proximity to where the people who need them are. Because when we were analyzing the cost of vaccination and the ability and capacity of our governments to sustain it, because the COVID vaccination needs to be sustained for a period of time, we do not see the resources there. So, but if you bring the vaccines and like doing what the South Africans are doing, refilling closer, I think that could create availability of vaccines, at least in the most foreseeable midterm. But it is not only vaccines, I must say, because we are also struggling to have access to the therapeutics which the rest of the world is already enjoying for people who, you know, we are treating with COVID. So that also should be something that is considered. But in a more short-term measure, governments in the global north needs to create opportunities to ramp up the pharmaceutical production capacity of Africa in preparation in the midterm for some of the technologies to be produced here within. And the African Union has been, you know, pushing forward with the creation of hubs, pharmaceutical hubs in the different regions of Africa, in Egypt, in South Africa, in Senegal, where there is some, in Nairobi, where there is some kind of efforts that they can quickly anchor onto. I think that could give us some quick wins. And then also, the last I should point is the cost of procurement of vaccines is quite high. And in some situations, we are paying more than what the developed North is paying. And looking at us recovering from COVID and then the sanctions, you know, that we've struggled with. For instance, we cannot access now vaccines from, if Russia chose to give donations of vaccines to Africa, we cannot. Relatedly, we've been purged towards accepting who to relate to, who to relate with, and where do we source the resources that we need to live or be. So I think that is also complicating our reality. Thank you.
So to Emma's comment about there being alternative models to finance and catalyze innovation and R&D, and to some extent also in manufacturing. But a key part of this is around finding ways to create more public finance and creating a greater degree of political support for the notion of the public interest, for the notion of public goods needing to be financed with public money. Currently, what we have is a major problem of imbalance with huge amounts of private wealth relative to a small amount of public wealth, both at the level of countries, but also at the global level. And fundamental to this is the requirement for regulation of the financial sector. At the moment, the financialization of the global economy has resulted in a financial system that is undemocratic, that is not properly accountable, huge amounts of power in the hands of private financial institutions. And then secondly, we've got a broken tax system. We've got a tax system that is non-functional at the national level, and we've got international banking and accounting arrangements that enable vast amounts of tax avoidance and tax abuse. So there are practical solutions for being able to generate the public finance required to be able to fund and deliver more public goods and more public services.
Thank you very much for that, David. And I think that's a really great segue into the next set of questions that I'd wanted to ask, which were kind of linked to this conversation around governance and accountability, both in terms of how we have greater engagement of governments, national governments, in the decolonisation, the decoloniality agenda. But I think, also picking up on the comments that both yourself, Anna, and others have made about the imbalanced contribution of private money, philanthropic money into the sector. What do you think are some practical next steps in kind of really reckoning with the governance and accountability of the global health architecture? It's a big question. I don't know if anybody would like to volunteer to go first. Anna, I'm kind of looking at you if you have any thoughts on that, but others, please do wave at me.
It is a big question, and as I said in my talking notes, and as David has alluded to there as well, I don't think we can isolate what needs to take place in global health with what is going on in the wider economy, and the need for new rules that restrict such huge imbalances in power and inequality. I said, and I really echo David's point about the need for wealth taxes and corporation taxes that work to draw resources away from these incredibly powerful actors, not just to raise the revenue that needs to be invested in public health and in public goods, but to curtail that power, to think about maximum wealth lines that we shouldn't be going beyond, to restrict that power and the way that power is wielded within global health. But within global health, when I started at Oxfam, one of my first advocacy focuses was around health systems financing coordination and looking at the chaotic architecture that exists. That was 15 years ago. That architecture is even more absurdly chaotic and opaque and untransparent, and these lines between decision makers and who is profiteering and extracting wealth from health have been entirely blurred. And that fundamentally for me has to be at the heart of fixing the system, is kicking those vested interests off of these decision-making bodies, returning. Did we ever get to a place where we had truly democratic multilateral institutions? But returning power to the WHO, returning power to other democratic spaces and making them more democratic, and reminding ourselves of the logic of conflict of interest, that we need firewalls, we need boundaries between those who are seeking benefit from the decisions that are being made in global health and those making those decisions. So I think it does require us to re-examine our global health architecture. It does require us to go beyond demanding a seat at the table for civil society, which has been a rallying cry for many in our sector for such a long time, but to actually reevaluate who has power within those institutions, and really calling for a redress of that power, that gives more power and more equity in decision making to different governments, to all governments, in that process.
Thank you very much, Anna. And I'd now like to move kind of from the top level of that process to thinking, as you say, about civil society and the role of community groups and communities as potential accountability drivers. And Sabina, I know from previous conversations with you that much of the work that you've done at BRAC around contextualizing the curricula has been heavily involved. There's been a heavy component of working with the communities around you. And I wonder if you could talk a bit to the role that that's played and how you see accountability within the global health system from that perspective.
So, thanks. I'll keep it brief, Emma. I think we saw with COVID, if you look at the colonial legacy, I mean, the way the country shut down, mimicking countries around the world, and we were in a completely different context. So you had public measures that were very biomedical: maintain distance, wash hands, wear masks. In many of the informal settlements, Dhaka City is the largest number. It's extremely congested, water's erratic, and it's expensive to keep washing your hands with soap when people were worrying about food and starvation. So public health in itself and the way public health is lived and experienced needs to be challenged in public health curricula. Back to my point, because we're creating generations and generations of leaders who go out there and join various organizations, and it comes back to a very one-dimensional view of the human being who doesn't exist. It's disease. It's very clinical. So I think that's one of my points. Two, we engage with communities in all of our courses. As I said, we have international students because we're going to talk about equitable healthcare. If we're talking about if public health schools or institutions or organizations were set up to help the most disadvantaged, then we have to begin with the communities. Like there's token, uses of word like localization, or token kind of brought on board and memberships and committees until you get vocal and then you're a troublemaker. There's also tokenism of communities where you bring them, they kind of have a bit of a say, but you proceed with the way you want to in implementation. But I think in public health, communities are at the heart of social justice, but also equity and improved health. And we do that in our James P. Grant School of Public Health because we were set up by BRAC. But I mean, more to the point of when I look at public health education and research, I was just thinking what we've created is a domino of effects, right? So one is certain kinds of knowledge is valued. There's a hierarchy of knowledge. Whether the competencies match or align or are relevant, even with COVID now. I mean, it shouldn't have to take us to COVID to realize there's a huge mismatch. But there's many different elements. So one, there's a predominance of certain kinds of disciplines, whereas in our context, I think you need to have a much more of a disciplinary approach. Two, then this relates to once you have a valuing of certain kinds of knowledge and education, and we kind of ape rather than learn from each other. So knowledge is multi-directional, and you've got a lot to learn from each other, and you've got to challenge and reflect. Then you've got the whole salaried positions, higher values of money. What is global? What is local? I often wonder about these terms. They're thrown about all the time. So if I sit in Bangladesh and I do research somewhere else, that would be kind of looked at as strange because I should stick to Bangladesh. Whereas global is a bunch of actors who may live in another country, preferably in a development country, and they can do all kinds of research. So, I mean, we can get into many discussions about research, salaries, journal publications, the way funding bodies are kind of structured, the way university systems are structured to create competition rather than solidarity. When you have a competitive sense of how many publications define your tenure track and how validated you are, that's all you're going to do. Tweet and have hundreds of publications. I mean, I'm being very dismissive and generalizing. Of course, that's not the case. I work with many, many very good people in public health all over the world. But I'm saying there's something fundamentally wrong with the way money drives, grants drive public health education, public health research. And even if you look at the way systems are kind of set up, someone had a question of what are the structures of colonization? It's everything: language, socialization, laws, legacies, policies, the way we dress, the fact that I'm speaking to you in English. We were colonized by the Brits. The fact that we value certain kinds of education, the fact that we can't critically reflect. And my final point is, before I stop speaking, is that I have made a concerted effort to bring in graduates from Liberia and Uganda who are brilliant to come and speak about public health in our schools, because they are dealing with and dealt with Ebola. They are dealing with some of the biggest research issues and are looking at contextualized solutions. So I really think we need to really deconstruct, dismantle models from the positions we're in, and not dismantle in terms of creating disruption. But some of it is disruptive, but to create meaningful engagement and also to create curricula that works and is actually relevant, builds competencies, capacities, and sustains engagement in a way that's much more fair, transparent. And I'm in a position I can be open in a panel. I'm open in many discussions, but many don't have that space. So we have to create that space. So I said a lot of things, but yeah, thank you.
Thank you, Sabina. As always, just so much to think about and dig into there. And it is a real shame, actually, that we're coming towards the latter end of this discussion. But I think what's been really great and what it has shown is that, the global health ecosystem is a fantastically complex one with many interlocking parts. And I think what today's conversation has shown is, they are not divorced from each other. And in order for us to really tackle this, it's going to need to be a multi-pronged approach that allows us to get at many different aspects, and then to think about the ripple effects of those, and to think about the incentive structures that we have, the accountability, the governance, who gets to sit at the table, should there be a table, what comes in the table's place, how do we fundamentally reimagine the system within which we're currently working when we're already inside it. So, at this point, I want to say thank you very much for what has been a really interesting set of presentations. And thank you very much to everybody who has contributed questions in the comment sections and in the chats. I'm so sorry that we didn't manage to get to all of them, but I do hope that you've enjoyed the conversation up to this point, and that, continue to get in contact with us. And we hope that we can pick up some of these other questions in fora going forward. At this point, what I would like to do is to pass to my colleague, Tiffany, based also at IIGH, who's going to tell us a little bit about some of the work that IIGH will be doing in the immediate term as we start to explore other aspects of coloniality and global health.
Thank you, Emma, and thank you everyone for joining us today and launching this program of work. We hope Decolonizing Global Health at UNU IIGH will not only facilitate discussion, but join a growing number of catalysts for action. As a first step, we will be launching a briefing paper series, which shifts us from broad critiques of the overall system to specific sites of action by presenting concrete criticisms of the status quo and potential solutions for debate and testing. This initial set interrogates the role of university rankings, health journals, think tank rankings, and private philanthropy in perpetuating coloniality within global health. These 4 areas of work were identified in part by a landscape analysis undertaken by Emma to align with problem areas often mentioned in the literature on decolonizing global health. Following the publication of that landscape analysis to set the scene for us, we will kickstart the series with a briefing paper on university rankings in roughly a month from now. But ahead of that publication, I'd like to share some of our initial thoughts and findings on this topic. And thank you. We started by asking ourselves, do university rankings perpetuate colonial ownership over knowledge production? We looked at the numbers from 2 of the most well-regarded global university rankings, the Academic Ranking of World Universities, colloquially known as the Shanghai Rankings, and the Times Higher Education World University Rankings. In 2021, as has been the case with all years before, the top quintile was dominated not just by the global north, but specifically by the United States and the United Kingdom. These two countries make up a disproportionate share of the list, made all the more striking by the underrepresentation of the three continents of Africa, Asia, and South America. The US and UK claimed 82 out of 200 spots on the Shanghai ranking, compared to a combined 45 universities across Africa, Asia, and South America. The disparities are even more pronounced in the Times ranking, with the US and UK claiming 88 spots compared to a mere 26 universities across Africa, Asia, and South America. A closer look at the world's top 20 universities as crowned by these rankings paints a similar picture, with the US and UK again claiming 19 out of 20 spots on both lists, and the remaining spots in both claimed by France and Canada respectively, maintaining the absolute dominance of the global north. Having established that university rankings do perpetuate colonial ownership over knowledge production, we then moved on to ask how and why. Upon closer examination of the origins, evolution, and criteria of university rankings, it became apparent that these metrics reward and reinforce the existing prestige, power, and privilege of established global north institutes, without consideration for how colonialism elevated certain universities to begin with, and how coloniality perpetuates this hierarchy. And could we have the next slide, please? Thank you. From bibliometrics that predominantly capture English outputs to awards that are determined by European bodies, it quickly becomes apparent why the global north is disproportionately represented in both overall rankings as well as subject-specific ones, such as the global ranking of academic subjects produced by Shanghai Ranking. These images, for instance, capture the 2021 global ranking of academic subjects for public health, which reflects a similar bias as its parent ranking. Beyond the usual methodological criticisms of university rankings, our briefing paper will apply a decolonial lens to this analysis to better illustrate how these rankings came to be, why their criteria perpetuate coloniality, and what first steps toward a solution might look like. And if we could have that final slide, please. Thank you. We will be bringing the same critical decolonial lens to bear on all of our analyses in this series, in the hopes that these briefing papers will serve as catalysts for action-oriented discussions with a growing network of collaborators and partners. Through this new platform, we look forward to collectively identifying more areas of concern and sites of change. Already, previous dialogues have alerted us to key topics such as the potential of global public investment as a way to shift power in the multilateral funding system, and the changing ways in which China participates in South-South collaboration. We look forward to expanding the scope of our work in concert with everyone who has joined us today and new colleagues we have yet to reach. That is all from me for now. Thank you, and back to you, Emma.
Thank you very much, Tiffany, for that introduction to the work. And just to let you know that as we start to produce those briefing papers, you'll be able to find all of them on our decolonising.globalhealth.org website, as well as through all the social media channels through which you heard about today's session. And so with that, I'd like to pass over to UNU IIGH Director Rajat Khosla to say a few words.
Thank you very much, Emma, and thank you sincerely to all the panelists and the participants of this conversation. This is my second week in the job and the first event that I'm doing with IIGH as I onboard myself as the director for the Institute on Global Health. And I have to say, what a wonderful conversation to begin the work at the Institute with. I have to say also that this was a very sobering and thoughtful conversation, and something that I guess we all have been thinking about in different spaces as we work together on the issues related to global health. Decolonization of structures, systems, and processes related to global health today is an imperative, not an optional add-on. As we all have heard the different speakers say so eloquently, global health as it exists today is not equal, diverse, or inclusive, nor does it have the tools to address the challenges of our lived realities. The multiple and intersecting inequalities that we talked about need to be addressed as a matter of priority. Global health, as some have very rightly stated, is yet to shed its colonial origins and structures. The supremacies which these structures represent are not symmetrical but complex and intersecting webs which continue to exclude the diversity of voices to maintain the hegemonic control which leads down to unjust and unequal global health agenda. The speakers have talked very eloquently also about reflecting upon our own powers and privileges from where we are situated and identifying the ways in which we need to move forward. Change that is needed at a substantial level, not at a rhetorical level. And it needs to rebuild and rethink systems across the board. What is important coming in from a UNU IIGH perspective is also to reflect upon how we built upon the work that has been done by scholars and institutions across a spectrum of specializations. We have colleagues working in, for example, in BMJ Global Health, at McGill, in other institutions. We have sister institutions within the UNU family and broader UN infrastructure, but also importantly, the work that has been done by civil society organizations and networks, such as the Third World Network, People's Health Movement, and others. Moving forward, it would require, therefore, not only rethinking the tools that we use in global health, but also the global health spaces. This would require us to identify ways to make meaningful, equitable representation of low and middle income country voices in global health structures, systems, and processes. And as Anna Marriott very rightly pointed out, not just having the seat on the table, but challenging who else has got the seat on the table, and therefore working towards a transformational shift. My colleagues have very rightly identified the next steps that we at UNU will be taking to the different areas of work in the coming weeks and months that follow. And we very much look forward to having you partner with us as we embark on this journey. Thank you very much for joining, and back to you, Emma.
Thank you very much for that, Raja. And so with that, all that really leaves me to do is to say a big thank you for joining us today. We've really appreciated all the comments in the chat. A thank you to our fantastic panelists for taking the time with us. And, do please connect with us through our website. You can email us at Decolonizing Global Health at UNU. You can find that information on the website as well. We have all of our socials. Yesterday was South-South Week. We've heard about the importance of learning from all directions. So particularly would love to hear more from our colleagues from institutions across the Global South. We'd also really appreciate your feedback, both on today's event, and you can scan this QR code that's currently on your screen to give us feedback on that. But also as we develop our website and the program of work, as you saw on the previous slide, there's the option and the opportunity to be able to give us feedback there as well. So once again, thank you very much. I hope to see you at future UNU IIGH webinars and events, and I wish you all the best for the week ahead.